No, he'll tell you why.
Hello, everybody. This is Hossein Maimani. I'm one of the medical oncologists with Rocky Mountain Cancer Center. And today I have the privilege of introducing Dr. Nallapareddy, who's one of our medical oncologists with Rocky Mountain Cancer Center. As you all know, March is Colorectal Cancer Awareness Month. And there's been a lot of discussion in the field of colorectal cancer as far as the rates of colorectal cancer, and has been a lot of in the way of research updates in the way we treat colorectal cancer. So today, Dr. Nallapareddy will be discussing some of the updates in colon and rectal cancer. She did her residency at SUNY in Buffalo, New York. She did her fellowship training here in hematology and oncology at the University of Colorado. She also did an advanced year in the field of gastrointestinal oncology, so she focused on that as far as research. She sits on our U.S. Oncology, Colorectal, and GI research committee nationally, and is very much involved in the field of research for colorectal cancer and advancing the field. So with that, Dr. Nallapareddy, I will go ahead and let you share your screen. And if anyone has any questions, feel free to write them in the Facebook comment section, and we will field those over to Dr. Nallapareddy.
Thank you, Dr. Maimani, for the introduction. And thank you, everyone, for joining our presentation today. As we all know, colon cancer, March is like colorectal cancer month. And colon cancer is one of the cancers which we all know is preventable, treatable, and beatable. So we want to raise the awareness about colon cancer, the research which is being done, and what are the screening recommendations. So our objectives today would be to get to know the risk factors, the screening, the stages of colorectal cancer, the treatment option, and things you could do to prevent the cancer. So just some facts about colorectal cancer. It's the second leading cause of cancer deaths among men and women, and it affects men and women both equally. And 1 in 20 Americans will be diagnosed with colon cancer during their lifetime. And over 60% of deaths due to this cancer could be avoided with screening. And 1 in 3 adults aged 50 to 75 are not up to date with the recommendation for screening. And over 75% of colorectal cancers can happen to people with no risk factors too. So being aware of the signs and symptoms is very important for the diagnosis of this cancer. So if we look, approximately 150,000 new cases are diagnosed each year in the United States, out of which 100,000 are colon cancer and 50,000 are rectal cancer. And statistics show that 50,000 people approximately die of colorectal cancer each year. If we look at the distribution of colorectal cancer, this is the colon, the right side, the transverse, the descending colon, and the rectum. 45% of cases of colorectal cancer occur in rectum and the sigmoid colon, and we will 20% in the 40% in the ascending and 15% in the transverse colon. And then if we look at the risk factors for colorectal cancers, if we look, the risk factors which increase the risk are mostly red and processed meats, alcohol, excess body activity, and also chronic comorbidities like diabetes, smoking, alcohol have associated with increased risk. There has been a lot of research going on in gut bacteria or gut microbiome. That's what we have been hearing in the last 3 years, more about the increased incidence and could it be associated with it. What it means is we all have bacteria in our gut, right? The bacteria, the names are called Bacteroides and Fusobacterium bacteria, which cause a protective layer to help us. But with all these lifestyle changes and the environmental factors, it looks like we are altering the gut bacteria, causing to cause increased inflammation in the gut and taking off the protective mechanisms we have to prevent the cancer. Because of this, we are seeing increased incidence of polyps and increased incidence of cancer. And there is a lot of research going on thinking, could it be the cause for young onset colorectal cancer to be on the rise? Not but least, we also need to be aware of genetic syndromes like Lynch syndrome and familial adenomatous polyposis. These are the syndromes which are not only associated with colon cancer, but other cancers too. So knowing family history is very important for everyone and also for the providers so that we can give recommendations for screening, not only for the colon cancer, but other cancers which are associated with these syndromes. But also, if you have family history of colon polyps, it's always important to get your screening process started earlier. Just for an example, I saw a patient this week. She's like 47 years of age, but her mother and sister both had polyps, and that prompted her provider to get her to the screening. And to her surprise, she did have colon cancer, but it was an early stage colon cancer. It was stage 2, and she didn't need any chemotherapy for that, and just surgery alone helped her with that. So knowing family history and being proactive with screening would definitely help diagnose cancers early and help with preventive measures. So if we look at the symptoms, okay, you're talking so much about colorectal cancer. What are the symptoms you need to be worried or watchful for? It would be like bleeding per rectum, like when you have bowel movements, if you notice blood in the stool, or if you have change in the bowel habits, like constipation alternating with diarrhea. Don't think it as irritable bowel syndrome all the time. It could be cancer too. So be watchful of that. Or other thing which a lot of patients complain is change in the caliber of the stool. Like thin stools or pencil-like stools should alert you for sure. And in the blood work, if you're anemic, especially if you have iron deficiency anemia on your routine physical, that should also be a red flag to look up and have more workup done. And not but least, unexplained weight loss is always should be watched for to see could it be anything else other than just losing weight and not to be happy with that. Okay, and as I was saying, if you look at the statistics with the incidence and mortality between the age groups, 0 to 49, you definitely see that there is increased incidence of the cancer, both in males and females from 1995 to 2016. But above 65, the rate is decreasing. And that's because of the screening colonoscopies, the rate is decreasing. But in millennials, their statistics show that they are almost twice as likely to develop colon cancer and 4 times likely to develop rectal cancer. And these are the statistics by the SEER database, which are showing that there is definitely increase in the rise for these cancers in younger population. So just be aware of the signs and symptoms and get screening done, because if you diagnose sooner, the treatment options better. And studies have shown that there is almost like 8 months lag period by the time you have symptoms to get to the diagnosis in young colorectal cancer patient. That's mainly because they are treated as like hemorrhoids if you have bleeding per rectum, or irritable bowel syndrome if you have constipation alternating with diarrhea, or if you're anemic, you're thinking of other causes. So definitely be aware of the signs and symptoms so that you can reach to your providers as needed. So next, coming to the screening. Why is screening so important? We all know screening saves lives, and there are not many cancers which have screening recommendations. The only few cancers are like breast, colon, and now lung cancer and prostate cancer. So definitely for colorectal cancers, screening has shown to cause decreased death rate because polyps are found earlier and removed, and you're diagnosing cancer at earlier stages than later stages where it's treatable but not curable. So now, okay, we talked so much. So what are the screening tools which are available? There are multiple, but I would stress on the stool DNA test and colonoscopy. Stool DNA test is a non-invasive test. You can talk with your physician. It's a stool test where we are looking for blood as well as tumor DNA in the stool, and that's very sensitive and specific test. If you go with this test, which is called Cologuard, you do it every 3 years. So if you have symptoms, maybe this would be the easiest test to get started. But the definitive test would be colonoscopy, which is where a gastroenterologist does the test with a flexible lighted tube to look at the entire colon. And once the colonoscopy is done, if it's normal, you don't need to worry for 10 years. But if you see polyps, then you need to get more frequently, like every 2 to 3 years, for the checking of the polyps and to have them removed. So when do you start the screening, right? So far, colorectal screening was mainly for patients above 50 years of age. And these recommendations are based on US Preventive Services Task Force, which is one of the agencies in United States, which gives recommendations regarding preventive services. And these are mandatory for insurances to provide them. So USPS Task Force and also American Cancer Society, the new recommendations are to start screening at age 45 years of age instead of 50. So American Cancer Society came up with these recommendations almost in, I would say, 2019. And USPS Task Force just came up with these recommendations in November of 2020. So there are some insurances which are still taking time to get to these guidelines. But if you have symptoms, you don't need a diagnostic colonoscopy. You can get a screening colonoscopy if you're 45 years of age and above, and you can tell them that you can fight with your insurances that these are the recommendations from USPS Task Force at this time. Okay, so that's about the screening. So what are the treatments and how does this colon cancer start? So this is just a diagram showing how it starts. This is the colon. It starts as a small nodule or an adenoma or a polyp is what it's called. All these are the same. So it starts like a small adenoma or a polyp. Then it becomes a larger polyp, and then it gets into dysplasia where these cells are dividing rapidly and haphazardly, and then it can form a cancer. And for an adenoma or a polyp, to form to a cancer, it takes 10 years. So that's why the screening recommendations for colonoscopies are 10 years. But remember, if you have a family history, or if you have polyps, or if you have certain genetic syndromes, this can get to cancer within few years, like 2 to 3 years or even 5 years. So the recommendations are different if you have high risk, meaning polyps or family history. So definitely follow the recommendations of the gastroenterologist if you have any of the high risk features. Okay, so these are like the stages of cancer and what are the treatment advances we have been having. So if you look at stage 1, it's just a small polyp. Stage 2 goes through the whole thickness of the colon. Stage 3 is going through the whole thickness and to the lymph nodes outside the colon. And stage 4 is where it goes to different organs like liver and lungs, which are the most common organs where colorectal cancer spreads. So if you look at the stages and the percentages, Stage 1, stage 2, and stage 3 compromise 75%. And I think this is all because of the screening guidelines. Stage 4, we see 20% of cancers diagnosed at stage 4. So if you look at the survival, this stresses the importance. Like if you are diagnosed at early stages, like stage 1, stage 2, or stage 3, your survival, 5-year survival is 67 or 70%. The survival rate goes down for stage 4, which is only 11%. So the sooner the diagnosis, the better survival rates, okay? And then coming to the treatment options. So what are the things we have seen and changed in colorectal cancer? If we look in early 1990s, there were not many treatment options for all stages of colon cancer. And the treatment we used were all like same dosage, same treatments for everyone. And there were only some cancers cured by surgery, like only early stages. And there was not major impact of cost on the treatments. But now coming into 2021, we have screening implemented, and there is treatment for many cancer patients, and we are getting to cancer as a chronic disease. It's almost getting to even for stage 4 patients, where we say it's like diabetes or high blood pressure, where they can still have cancer and live for years with these diagnoses, with all the new treatment options we are having with impact on survival. But also what we are seeing is with all these new treatments, we are seeing major cost impact also with the treatment options, which I'll go over more. So then what are the treatments for the cancers? If you look at stage 1, we just do surgery for either colon or rectal cancer. Surgery alone is 90% chance of cure, as we said, and patients don't need any additional treatments. But for stage 2 and 3, you do surgery. And for stage 2, you give chemotherapy for some high-risk patients. So who are these high-risk patients and how do we diagnose them? I'll go over later. And for stage 3, we do surgery and give chemotherapy for 6 months for all these patients to improve their overall survival. Rectal cancers are slightly different, where we also add radiation therapy to rectal cancer for stage 2 and 3. And for stage 4, it's mostly chemotherapy is the treatment. Sometimes we do surgeries for patients if they have like obstructive symptoms, or if they have such a great response, or if they have only one spot which is spread in the liver or lung, then we even aim for cure for stage 4 colorectal cancer patients. So what are the treatments for stage 2 and 3, and what are the changes we have seen in the last 3 to 4 years? So the treatment for stage 2 and 3 is called adjuvant therapy. So we add some treatments for these patients after surgery. Just for stage 2 cancer, to give you information, 80% of patients with stage 2 are cured with surgery alone and have good overall survival. So there are 20% of patients who it can come back in the next 5 years. So even in that 20%, it's 5% is the only where you really benefit from chemotherapy. 15% don't have any benefit of chemotherapy. So that's why for stage 2, we don't recommend chemotherapy unless they have high-risk features, like if they had obstruction or perforation, or if they didn't have enough lymph nodes which are removed at the time of surgery. Any patient who gets colon surgeries should have at least 13 lymph nodes removed at the time of surgery. If they are not removed, that's something to talk with the surgeon. And then for stage 3, where I showed that there was only like 60% cure with surgery alone. So there are 40% where it can come back. What it means is like if you have 10 patients, 6 patients are cured with surgery alone. There are 4 who have the recurrence, and out of 4, only 2 benefit from chemotherapy. But we don't know who are the ones who really benefit from chemo and who do not. So we recommend chemo for all stage 3 cancer patients for 6 months. But good news coming in that way, where we are using some other things to see who are those 2 patients who can benefit from chemotherapy and how long do you need to give chemotherapy for these patients. In news, you might be seeing there's a lot of information being talked about circulating tumor DNA. So this is a newer technique which is coming in, and this might be one thing which we might even have it when you go to your primary care physicians in future, where they might just take blood sample, and if you have any cancer, there might be DNA floating in the blood, and they might take that blood and do screening for cancer and say, okay, you have a high risk and you might need to talk and get more screening or testing to diagnose the cancer. So those are coming. We even at RMCC, we participated in a study called GRAIL study, where they compared patients with cancer and without cancer. And that study looks like had positive results. But coming to our stage 2 and 3 colon cancer, so when we look at this circulating tumor DNA cells, how it is helping us is we had like almost 3 or 4 studies presented this year at our big GI ASCO meeting, which is our big meeting. So what they did is after surgery in stage 2 and stage 3 patients, they took the blood and looked for tumor DNA. So if the tumor DNA was negative in these patients, their chances of relapse was very low. So they didn't have chance of recurrence. If the DNA was positive in the tumor in the blood, then they had high chance of recurrence rates. So if you look at these graphs, in the patients who had positive DNA, it was almost 80% that they would have the recurrence. If it was negative, it would be less chance of recurrence. And this is another looking after the treatment. So this is for stage 3 patients who had chemotherapy after surgery, and they followed these patients with this tumor DNA cells. And what they showed is patients who had negative tumor DNA did good compared to patients who had positive DNA. So that's something which is telling us to identify patients who really need chemotherapy for stage 2 and stage 3 patients. And can you follow these patients closely with this testing so that you know how to follow them, and if you can be more aggressive in patients who have positive DNA and diagnose the cancer earlier than they would have symptoms or seen on the CAT scans. So that's something which we all are adopting now. And then something also for these patients, which came up in the last 2 years, is a study which consolidated data from all previous studies, which is called IDEA study. I wanted to show you this study just to stress the importance that we always don't want to do too much for our patients. Less is also good in helping our patients. So in this study, what we showed is 3 months versus 6 months of chemotherapy, there was no benefit, there was no difference. So what it's telling us is like for stage 3 or stage 2 high-risk patients, like 3 months of chemotherapy is enough than going for 6 months of therapy. And also they compared with 2 different regimens. These are the regimens we use for stage 3 and stage 2. And what it showed is both the regimens are equally effective at 3 months is as good as 6 months. So based on these studies, we are trying to give less chemo for our patients and also help them decide who are the ones who really need the treatments. And for our stage 2 and stage 3 patients, they always ask us, okay, what can we do to keep this cancer from coming back? We are done with the treatments. What are the things? That's when the anxiety for the patient gets higher because they are done with the treatments and they want to know what they can do. So what the studies which have shown, one is the use of baby aspirin. This slide is little crowded, but what I want to show is aspirin has shown to improve chance of disease recurrence in patients with colorectal cancer. It's only helping patients who have a specific mutation called PIK3A, but it's hard to test for that. So I tell all my patients with stage 2 and 3 to get on baby aspirin. and that should help in prevent the recurrence of polyps and the cancer. And also, the main important thing which I stress for my patients is physical activity. They need to be on a good exercise program, almost like more than 17 MET hours, which is like half an hour moderate intense activity for 5 days a week, is what has shown to really decrease the risk of colorectal cancer recurrence. More than aspirin and other things, it's the exercise which has shown really to help. There have been also a lot of data coming up with circulating vitamin D levels showing decreased risk of colorectal cancer. So I also make sure my patients' vitamin D levels are within normal limits when after they are done with all the treatments and follow that. But also like less servings of red meat. I tell them like not more than 2 to 3 servings a week, and more fruits and vegetables, to get at least 3 servings of fruits and vegetables in their diet has shown to help really decrease the risk of cancer recurrence. So that's for early stages. So what do we have what's going on new in stage 4? Stage 4 is where cancer has spread to other organs like liver and lungs, as I talked about. So if you look at the history of treatment of colorectal cancer from 1960s to 2020s, we had almost like 12 drugs which got approved during this period, from chemotherapy to targeted therapy to immunotherapy. And this has really helped us to help improve the survival. The survival without any chemotherapy for stage 4 colorectal is up to 6 months. And now with all these biologics and everything, the book numbers say 2 years, but we are even seeing patients up to 5 to 6 years. I had one patient, he was almost like 82. He just passed away with stage 4 colon cancer, but he lived up to 6 years with all the newer treatments and we are having for the colorectal cancer. But all this is not coming without the expense. Just to give you an update, like the 5-FU is the drug which was approved in 1960s, and it's a chemotherapy drug. These are the top ones, are mostly chemotherapies. The chemotherapy, this is the price. Compared to these are the other drugs, the second line is targeted therapies, and the third line is immunotherapy and targeted therapy. We are improving the survival, but we are also improving it at a cost. So then comes like, how can we help the patients with minimize the toxicity, cost, and everything, and personalize the therapy for each patient? So these are all the drugs we have. This is like a puzzle where we have all these drugs. How do we use it for our patients? So with all the new treatments, we also are doing a lot of research to see which treatment is right for patient X versus patient Y to patient Z. So we don't treat colon cancer as one disease. It's treated as more than one disease. We look at anatomic sites, right versus left versus rectal. Right-sided colon cancers do not respond to certain treatments. So why give those treatments for those patients? So we do tailored treatment different for right versus left colon. Young versus old. Elderly patients cannot tolerate 4 drug combinations. So we try to do 2 drug combination, or if it's a young patient who is aiming for cure, we may even go for 4 drug combination for those patients. We are looking at stool flora to look at what are the treatments we can give. And we also look at molecular markers. These are the markers on your cancer which we look at, and personalized treatment for you. If you have MSI high tumor versus MSS stable, the treatment is different. If you have RAS wild type versus mutant, the treatment is different. BRAF wild type versus mutant, the treatment is different. If you have HER2 positive, you have a drug which works for you. The reason I'm showing you all this is these are only subset of patient population who can benefit. So it's not one thing for everyone. And as I was saying, the right side versus left side, totally different, and the treatment options also change for that. And so what is this personalized medicine? So personalized medicine aims to individualize medical treatment specific to the patient, and so that that patient can benefit more and less risk of side effects for that patient. So these are the molecular markers which we test for every stage 4 colorectal patient who comes to our office. We test for all these molecular markers on their biopsies and tailor treatments specific to them. So just to give you an example, so this is a tumor cell or a cancer cell, and this is a blood vessel in the tumor cells. So these are all the receptors which we are targeting. So that's why these are called targeted therapies. So this is a receptor called vascular endothelial growth factor, which we target with these drugs called bevacizumab, ramucirumab, or aflibercept. And this is another receptor on the surface of the tumor, which is called epidermal growth factor. So we target these receptors with these drugs called cetuximab and panitumumab. And there is downstream signaling going on in the cancer cell leading to their growth. So we are trying to block each and every path of these cancer cell growth with the specific targets. So we are going more towards targeted therapy at this time. And this is just an example for you to show that the targeted therapy called bevacizumab, when added to chemotherapy, definitely improved overall survival for patients from 15 months to 20 months, which is 5-month overall survival improvement, which is really significant for stage 4 colorectal cancer patients. So we are also looking at these biomarkers. These are the markers in the tissue and also sometimes in the blood. And these markers will help us. They are predictive biomarkers, which tell us if the drug is going to work in them or not. And there are prognostic biomarkers, which tell us that the cancer is aggressive and we need to be aggressive in the treatment for those patients. Just for an example, this is called KRAS, is a predictive biomarker. So patients who have KRAS mutant do not benefit from these drugs called cetuximab or panitumumab. So we give it only to the patients who have KRAS wild type, and that's only 15% of patient population. So we are trying to minimize like giving the same drug to everybody so that it's not given to one who are not really benefiting from it, and really tailor it to the ones who can really benefit from it. So that's targeted therapies. But nowadays we are hearing so much about immunotherapy. So what is immunotherapy and how are we using it in colon cancers? So what it is, it's a tumor cell, and these are T cells or immune cells. Our immune system should be able to fight the cancer because it's foreign, right? But this is not able to fight because the cancer cells protect themselves with these things called PD receptors. They are forming a guard to them so that the immune cells cannot work. What immunotherapy is doing is coming and taking off this guard or the protective mechanism so that your immune cells get activated and kill the cancer cells. And that's been the thing which we are hearing a lot in all cancer types. And we are trying to see if we can help that for our colorectal cancer patients too. And just in the last 3 months, we had a study based on which we got approval for immunotherapy for patients with colorectal cancer for a subset of population, though it's not for everybody. It's only for patients who have MSI high tumors or microsatellite unstable or mismatch repair deficient. Those are the subset population who benefits from immunotherapy. And this study, this graph is just to show that the red is chemotherapy and the blue is immunotherapy. Patients who are on immunotherapy are definitely doing good, and they have stable disease for prolonged period of time. So in this study, just to give you an example, like some patients could even come off the chemotherapy immunotherapy, after 2 years, their cancer was completely gone and they are just off the therapy without the cancer. So we are seeing some great responses with immunotherapy. But as I said, it's not for everyone, it's only for subset of population. So we are doing studies to see how about getting immunotherapy for everyone. So there are some drug combinations which are being studied at this time to get immunotherapy for other population too, where I said it's not approved at this time. So select the right treatment for every individual patient is what personalized treatment. Are we there? We are getting close to there, I would say, with all, at least in my 10 years of the practice, I'm seeing tremendous changes in the treatment options available for our patients, and even patients with stage 4 are living longer and longer. And the talk cannot be completed without talking about prevention, right? What are the things you can do to prevent colorectal cancer, just general population? The things are like increased fiber in the diet, less consumption of red meat and processed foods, decrease smoking and alcohol, increase exercise, aspirin 81 milligram for population above 50 years of age, making sure your vitamin D levels are in the normal levels when you do your physical. So these are the things which can help you. So I think some take-home points: keep up with your screening colonoscopies, do preventive stuff to help with decreasing the risk for colorectal cancer. And if you have symptoms, don't ignore, and definitely talk to your primary care provider and get your screening and follow up on the things. Yeah. Thank you, everyone, for your attention. We're happy to take any questions too.
Great, Dr. Nallapareddy. That was just a wonderful overview, from prevention to updates as far as treatment. So very thorough, and the patients have all had great things to say on our Facebook page. I had a few questions for you. One is from a standpoint of prevention and from an epidemiologic standpoint. As you mentioned, the gut biome is very, very important. As far as an intervention, and I know everyone's interested in it because, reestablishing the gut biome and changing the gut biome is very well researched, even for immunotherapy, for example. But is there any advice that you give your patients as far as considering any probiotic therapy?
Yeah, I don't think that we don't have data enough to just say like yes or no for probiotics. But as we said, we are definitely altering the gut microbiome with our lifestyle and environmental factors and everything. I'm not, for my patients, I don't have any pro or no because I don't really have the data to show with probiotics for CRC patients. As long as they're okay with taking it and they don't have any contraindications, it's okay. But for my patients who are on active treatments, I tell them to be cautious with the probiotics. I think we need still more data in terms of probiotics to really know how much it's really helping or harming the gut microbiome.
And it's so hard with standardization. I think that's part of the issue, with probiotics.
But there are a lot of studies going on, like GIASCO. We had so many great presentations where there are a lot of research going on too. So if patients have the chance to participate in that, I would definitely encourage them.
So I have a really excellent question for you from Aaron Beauchart. I hope I'm pronouncing that correctly. So the question is, do you look at tumor mutational burden with regards to treatment?
Oh, that's a very excellent question. Yeah, so that's a good question because tumor mutation burden, what it is mutations are changes in the genes in the tumor. And the more the mutations you have in your tumor, the more the response for immunotherapy. So far, it used to be only in MSI and MMR deficient tumors that immunotherapy was approved. But just in the last few months, we had immunotherapy approved even for patients who have high tumor mutation burden, which has to be more than 10 and above. And the drug pembrolizumab has been approved for patients with high tumor mutation burden. And we do check it for all our stage 4 CRC patients. We check for that.
Yeah, and the bigger question that always comes up with tumor mutational burden is, do you try to take it a step further, and do you try to look at Yervoy in combination with Opdivo for tumor mutational burden? And I know that we had been recruiting patients even at Rocky Mountain Cancer Center for that clinical trial. So that's a really good question. So
yeah, we do have that study still open for the patients. Yeah.
Another question I have for you, and I thought the most fascinating slide was the cell-free DNA slide.
Mm-hmm. Circulating tumor DNA.
Yeah,
mm-hmm.
Yes. So the circulating tumor cells and this topic of cell-free DNA, even, we've been talking about this for almost a decade, it seems like, but it's always hard trying to separate these stage 2 and stage 3s. I mean, how aggressive should we be? And we're looking at anatomic risk factors and pathologic risk factors, but when do you think that's going to be prime time? Because that would really change the way we treat those early stage patients.
So at GI ASCO, we did have some studies presented, and we do have this test. It's called Signatera test, which I have been trying to use in some of my patients. And also there are a lot of clinical trials going on in stage 2 and stage 3 colon cancer patients, how to really use them. We know that it's really going to help us, but we still need to learn a little bit how to really use that in real-time practice. But I have started using it in my stage 2 and stage 3 patients, the Signatera assay test at this time, to see if I can help them out.
Yeah, that's, once that kind of gets incorporated, I think that'll really be practice changing.
Mm-hmm. Yeah.
So otherwise, I don't see any other questions. So, if anyone has any questions, feel free to type them. Even after the fact, if you're watching this at home later today or later next week, feel free to ask a question to Dr. Nallapareddy, and we'll route that over her way, and we'll answer those questions. Judy had mentioned no questions, total appreciation for you and your team.
Thank you.
So a lot of very kind comments through Facebook directed at you. So, well, again, Dr. Nallapareddy, I very much appreciate what you're doing and for advancing the field and really advancing cancer care in Colorado. And you've really helped advance Rocky Mountain Cancer Center as far as our research in colorectal cancer, and the presentation was phenomenal. So
thank you very much, everyone. Thank you very much, Dr. Memani, too. Yeah. Thanks.
Okay, take care.
Bye.